Okay, are we ready? We're ready. Showtime. So today I present everyone with a very interesting case. We have a patient who has presented with a chronic pain to the medial aspect of the right ankle. This patient has been battling this for a very, very long time. She presented to us for further recommendations. When she presented here, not only did we perform an ultrasound, but we also sent the patient for an MRI to identify the problem, which turned out to be a tear, a split longitudinal tear of a very important tendon in our ankles. So what I've done here for teaching purposes, there are three bones that make up the ankle joint. We have the tibia, the fibula, and the talus. So on the medial aspect here, we have the tibia. That's why I've kind of just painted here, drawn here over T for tibia. So we have the tibia. On this side of the tibia, we have very important tendons, including this particular one, which actually holds up the arch. And as we get younger, right, or number one, in this particular case, the patient is diabetic, she's getting younger, this particular tendon starts to and could degenerate. So the point where it starts to actually just tear. So unfortunately, she presented to us, we identified the problem with the MRI, and the patient is not interested in surgery. So we're taking a different detour/route, and we're recommending a percutaneous microtenotomy, the dry needling that we always usually do, in conjunction with the PRP. So we've drawn quite a bit of blood. We have already spun it, and we've isolated the platelet-rich plasma. And again, we continue to do a lot of PRP, whether it's PRP, stem cell, any regenerative procedures. A lot of patients that at first glance maybe physicians may think that they're candidates for surgery immediately. That's not the case. We try to really avoid the knife. We do know what clinical presentations will respond to certain specific pathologies and problems that patients come here with. But in this particular case, could surgery fix the problem? Absolutely. For other reasons, the patient has elected to proceed with the above mentioned procedures. So without further ado, the first part of the procedure will entail the microneedling, or the dry needling, or the percutaneous microtenotomy. And basically what we do here, and again, I've drawn here, this is where the tendon moves, makes a U-turn here, and it inserts into the NAV, that's called the navicular bone, okay, which is a very important bone along the medial aspect of the foot. So what we're going to go ahead and do is, again, we basically just slowly fenestrate, and I can feel it. I can feel the tendon. And it's not just sticking the needle in there. It's not like that. What we very slowly, just very carefully, there, the patient felt a little something there. My apologies. I'm a nice guy. And then last but not least, we'll do that one a little bit on the quicker side. So that's the first part of the procedure, believe it or not. And again, the reason why we do this is we want to attract tendons, ligaments. These soft tissue structures are very avascular. They don't have a lot of blood supply. And what we're trying to do is basically, we want the brain to send all these wonderful cells and we want the body to send more blood supply, more blood to the area to really heal, in this case, this tear. So now we're going to go to part 2. Okay. And what we're going to go ahead and do is we really drew a lot of blood today, and the more blood we draw, the more concentration of platelets we're able to isolate. We have 3 and change here, and we have some more there. So what we're going to do is I'm going to start just to right about here. Okay, we'll test anesthesia first. Any discomfort there? Okay, and I'm going to slowly go in, and we slowly infiltrate on the way back. Very slowly, very slowly.